everybody. My name is Jordan. I'm one of our new patient advocates. This is Dr. Zelensky. Today we're going to be going over a webinar presentation for care for brain injuries and the lingering symptoms at mind-eye. I will go ahead and let Dr. Zelensky do an introduction, and we'll take it.
Hi, well, I'm the founder of the Mind-Eye Institute that used to be called Mind-Eye Connection, and am here to answer questions on what we do, how we work with other practitioners, and what happens when you have lingering symptoms from brain injuries. So Jordan, I think you had some questions that people had sent in beforehand, and then we have people in the audience that can be asking questions now.
Yeah. Do you want to go ahead and knock out those questions first and then do the presentation after?
Oh, well, no, I'd probably do the presentation first. So let's try that.
All right. Yeah, if you do that, then we can do those questions, and then if people also have questions during and they want to send anything in as well, we'll be adding to that list of questions as we go. So if there's anything that you have questions on throughout, just let us know.
Okay. The overview of neurotypical visual processing. We used to call it normal visual processing, but that's not politically correct anymore. So the non-brain injured patient, or the non-developmental delay or the non-genetic mutation patient, there's processing on the outside where we see an object, that's eyesight. But then there's a lot of processing going on the inside about thinking, about planning. So the example I use often is Walt Disney, where he's a visionary because he looked at swampland in Florida and was able to picture Disney World and Disneyland and say, look what we could build. That's an internal visual process. But the outside, what you see, and the inside, what you do with what you see, are two different things, and they blend together for visual processing. But there's also something called non-image forming signaling. And that means that the retina itself, the lining of the eye, is an actual piece of the brain. And there's signals that when light strikes the retina, the signals are transmitted through the optic nerve to places in the brain that have nothing to do with eyesight and nothing to do with visualization. People are familiar with this from jet lag. So sleep is one of the big connections that's non-image forming. There's emotional regulation and sugar regulation. Lots of other things are linked with retinal processing that don't have anything to do with eyesight. So there's three basic buckets: the outside, the inside, and these non-image forming signaling. So from the objects, if you take the outside, you have central eyesight to see details, and then you have peripheral eyesight, which is faster, and it's used to keep you safe and judge where objects are. So if you think of something moving in the corner of your eye, affecting the peripheral eyesight, you can say it will be attached to your fear centers. Because if something moves suddenly, then you say, whoa, what is that in the center? Am I safe from it? And turn your attention and put your aiming and focusing on that object to see what it is on the outside. And then in the inside, go through, well, here it is. It was just a cat that jumped off of a table, so it's not dangerous. Or it was something that rolled down the street, a bag that blew. If anything moves in the corner of your eye, you go through the outside, catches it, the internal systems get activated, and then the internal thinking systems get activated. So we use the peripheral a lot more than the central eyesight. So for instance, if you're driving, you only use your central eyesight to read a street sign or read a license plate. Most of the time you use peripheral eyesight. And peripheral eyesight is known more as a where is it pathway, because it navigates where an object is in your environment with respect to you. But then the central eyesight is known as what is it. So the outside objects, you got the where is it and what is it pathways. Then you have the inside, where you're visualizing an object. And the visualization of the object can be based on memories and related concepts, And the memories are each linked with an emotion. So when something happens to you, there's systems in your brain that remember it, and then other systems that link an emotion to it, and they go together. So that when the same thing happens again, it pulls up the emotion. So if you get, if you're poor at one subject in school, and then the teacher says, here, we're having a pop quiz on this subject, the emotions might be, anger and frustration and embarrassment and different from if you like something and the teacher says, hey, we're going to have a pop quiz on that subject, and you might be great. That sounds terrific now. So the internal systems, you've got the visualization of that object with the memories and emotion. And then you have a lot of different visual perceptual skills. And those are different depending on who you are and the decision of what should I do about it. So when we at MindEye are evaluating patients, we're not just looking at their central eyesight, can they see 20/20? We're looking at their peripheral eyesight, how quickly they react to things on the sides, how they aim at a target, how they think. We're looking at the visualization, how well they can remember details, and many different visual perceptual skills. Then you have these non-image forming pathways, which link with how am I, how much energy do I have? And that's what I alluded to before when I said one of the non-image forming pathways was glucose regulation. Am I safe? There's signals in the surroundings that you can feel safe or not. And do I care? Is something that I have to do or something that I want to do? Because if I want to do it, I'm going to have a different emotion than if I have to do something. And then there's another non-image forming pathway that's a fairly big one on postural stability and your body position and you against gravity. And that's nicknamed where am I? So here's where the non-image forming pathways are. They link with the brainstem and the midbrain and the hypothalamus. And the image forming pathways link with the part in your brain that's used for eyesight. So when the eye exams were invented, people thought that there was just the eyesight part. And about 25 years ago, a lot of the non-image forming pathways were discovered, but they weren't using eyeglasses to influence them because the discoveries were in neuroscience. And one of the things MindEye does is connects neuroscience discoveries with optometry. So here's a different way of looking at the non-image and image forming, where you have the slow signals of the where and what is it. And you also have when is it. This is space and time. Then you have the faster non-image forming signals of how am I, where am I, and am I safe. But the inside of a person doesn't always represent the outside. You can look fine on the outside, but you don't feel good on the inside. This is a slide from the concussion community's website. I think it's a great slide because a lot of our brain injury patients come in and say, I feel horrible, but because I look normal, the doctors just brush it off. Or I score 80% on all the tests they give me, and the people tell us, well, 50% is average, you're 80%, you're way above average, you're good enough. But before I had my injury, I was 99%, so I'm not me yet. So this is just a different way to see. You have central eyesight as the slow pathway. You have peripheral eyesight. Those are your eyesight pathways. And then you have the postural stability of your neck, your hips, your ankles. And then you have your body regulation with emotional regulation, glucose regulation, sleep, and appetite. So the body regulation and the postural stability are the non-image forming group. The peripheral eyesight and your central eyesight are the eyesight group. And then inside your head, the visualization and imagery and memories, those are all the third group. So we have patients that talk about problems and we kind of separate them into sensory signals, motor skills, emotional regulation, and thinking, because they're from different brain pathways. And this is kind of a timeline here. that the world keeps changing, but the eye exam still uses a 20/20. And the bulk of the population are fine with this testing. But after a stroke or a brain injury patient or people with autonomic dysfunctions or seizures, or anytime your brain isn't working optimally, even somebody with learning problems, or people who are just neurodiverse, where they're fine, but they have a condition, such as some genetic mutations or some autistic spectrum. The, they need more testing. So this slide was talking about how there's a human genome project, there's a human connectome project, and they're just now starting with something called an oculome and oculomics, which is using the eye to find biomarkers of things happening in the body. So I'd like to take some of the questions. What we're fitting in with is other practitioners. So there's motor practitioners like physical therapists and occupational therapists and chiropractors, and there's lots of different motor therapists. There's reflex integration specialists. There's neuro movement specialists. There's also sensory processing practitioners for auditory and visual. And there's thinking related practitioners like Donnelly Marcus and her Designs for Strong Minds. And so what we work with is the relationship between the outside signaling, awareness and attention, and how it has an effect on the posture, the gait and balance and midline shifts. And then we're putting glasses on to change the environment, which would lessen expended energy. And we would work with the other practitioners who would then solidify the habits for motor and sensory and thinking. One of the things we do with our glasses is make the eyes and ears connect, because you have signals going in your ears from the peripheral part of the ears and the central part of the ears. And then you have signals going in the peripheral part of the eye and the central part of the eye. And so there's 8 different channels because you have the right side and the left side. There's body language, facial expression from your eyes, and the tone of the voice and the content of word choices from the ears. So this is a layout of what I just said for the last 15 minutes, where you have processing in the retina itself. Then you have unconscious, subconscious, and then you actually have pre-conscious and then conscious visual processing. And there's a lot of different things that happen for muscular systems, chemical systems, but the mental filtering, this is where your personality comes in. And it says, who am I? And each person is different for mental filtering. And depending on who you are, you make a decision. So I've often quoted Jonathan Penner in many different lectures. Jonathan Penner wrote a book called Going Blind 20 years ago, 25 years ago. And in his book, he said you can split people up by putting them out in a rainstorm and giving them a book. And he said, depending on who they are, some people will use the book to shield their head, and other people will use themselves to shield the book. And it was pretty interesting. I've always liked that, because the conscious decision of what am I going to do with this book depends on who you are and how you value the book. And that's what we watch. So this is a little bit of balance when you have motor control of the head. So it's talking about different reflexes. But to make this a little simpler, you've got your body against gravity. That would be the where am I. You have your head versus your body, your eye versus your head. The eye versus your head is where is it? And then you have the target location versus your eye position, whether it's the close to you or far away, and that's more depth perception. So you have other reflexes. If you move your body like a baseball player, if they're swinging a bat, their head stays pretty still and then the body swings under them. So if you have a brain injury, you can still rebuild your visual skills. So there is a mind-eye connection with a lot of different signaling pathways. And then there's a lot of non-image forming pathways like the posture and then the body functions. So the goal at Mind-Eye is to know that eyesight is important, but the visual skills have a larger roles. And then we can split the visual skills and build them up. And I put together VISION for vision, to handle the different types of activities that we provide patients for building orientation, navigation, sensory integration, isolation of eye movements, and the V for visualization. So my mentor is Albert Sutton, and the Mind-Eye team has been invaluable in setting up things like this webinar. So I'm ready for questions, Jordan. Oops.
Awesome.
Go back to the,
Yeah.
I'm going to put it back to the particular slide. So that this one here, actually, this is the timeline, and then this is the other slide here. I put these two back together, so when people ask questions, you'd probably use this. Okay. Thanks.
Perfect. Yeah. Thank you for that, Dr. Zelensky. And yeah, I apologize for some of the people that were having some technical difficulties joining on there. We had some issues there, but it looks like we've got a fair number of people that are in now. So, we'll go straight into the questions. If for any reason we don't get to your question, if you're posting any questions right now, please leave those in the comments. Leave an email address if you can on that, and we'll get to that question as soon as we're able to. We'll send you a response on that, and we will be doing a replay of this webinar as well. Well, yeah, so let's hop right into the questions here. We'll start off with Don's questions. He has major balance problems, not dizziness, just a lack of body awareness where he is. He's been developing eye gaze issues and eye dryness issues, walking, gait, and leg movement problems, and then pain issues primarily in the legs and hips, overwhelming stress, feeling of hopelessness, things like that. And he had a car accident a year ago. So he's wondering, are those things that we can help with? Is he a candidate?
The short answer is probably, but that sounds like something we could work with other practitioners on. So I'd want to know, is he currently working with any person on balance and dizziness? Because if you have gait movement problems and postural stability and pain in your hips, so the answer is yes, we could combine with the body worker that you're working with, because if you're having pain in your hips, it means you have to rotate your hips a different way. And we can use glasses to shift things outwards with one eye or outwards with the other eye. That would induce a hip rotation. We could also make the floor tilt up or tip down, so you'd lean forward or backwards, and that would put less stress or more stress on your hips. So we could use glasses to shift your center of gravity, make the postural stability a little better, but then you could work with your practitioner on like rehearsal of building new brain pathways. Okay. As far as the dry eye goes, dry eyes often come from stress. The more stress you're under, the drier your eyes will be. And so if you're under stress because your hips are painful and you can't walk and you're always scared of losing your balance, then the dry eyes might go away once your balance is more comfortable.
Why does stress cause dry eye?
That's a good question. Because calmness causes moist eyes, because the norm to be would be calm, and when you're very calm, your eyes are moist. Stress causes your whole autonomic nervous system to go into fight or flight mode, and when you're in fight or flight mode, your brain prioritizes what it does. So, for instance, your bladder stops. You don't think about urinating because your body needs to be running around. Your eyes get drier because the secretions stop in all of the different glands, because your brain needs the energy, everything for the muscles to be running. It needs blood flow. So all the secretions kind of stop when you get in fight or flight mode.
Got it. Okay. Well, these are good questions here. So we just had a couple come in for international clients. What would a treatment plan look like? Do we do visits online? What does that look like?
We have a lot of international patients. We actually, before COVID, had an incredible amount from Amsterdam due to Ava Crook telling people about Mind-Eye Institute. so what it looked like internationally was if somebody had some sort of head injury or brain injury, we would set up, first we would do a history to decide whether they would just see us or whether they would see us and other practitioners as a team. When they came, uh, if they were just seeing us, we could work within a handful of days. If they were seeing other practitioners also, they would see us, possibly get a pair of lenses, work with other practitioners, and then come back to double check what had changed, and then go back to their other countries. So that could be up to 2 weeks. But we had many patients coming in, for 3 or 4 days and then just turning around and going back. So is that what they meant as far as what does it look like?
I think so. I think so. Yeah. I mean, as far as follow-ups and things, I mean, they, obviously they'll come in for an evaluation. I know that we do have some, practitioners that we'll do remote patient appointments with.
Yes.
And
We have, so we have practitioners in different parts of Europe and in Mexico that can kind of be our hands. And so the patients could come here for an initial evaluation where we do an extensive several-hour assessment. And then when we pinpoint where the problems are, then they go back and they would see a practitioner in another country to be like on a Zoom appointment where the practitioner would measure things and then we would help guide into what type of glass modifications were there. Meanwhile, we have a visual rehab staff here that could be working with them on Zoom to build up visual skills.
Perfect. Yeah. She also asked, is there any screening questions or someone to assess if someone would benefit from the treatment, which actually is probably more of a question for me. PI, if you want to fill out a new patient inquiry on our website, myself or one of our new patient advocates will get in touch with you and we can kind of go over your situation and discuss whether or not it is going to be something that we can help with. So we're always happy to do that.
I mean, everybody's very different. So, we don't want to put false hope into somebody. And we want to make sure that when you're in a timeline of recovery, that you work with Mind Eye at the proper time. So if there's levels of processing, and if there's an issue, say emotionally, that has to be dealt with first, then that should be dealt with before, because the Mind Eye glasses are just bending light and they're giving you the opportunity to change. But if you're not in the right mindset to change, sometimes we'll have patients dragged in by siblings or parents, and if they're not in the right mindset, it's you can bring a horse to water, but you can't make them drink. So the patient needs to want to change. Or if it's a child that doesn't know enough, or we've had many near fatal drowning patients, then that's different. Then they need to be seen. But there's a lot of screening that has to be done to determine whether you'd be an appropriate candidate. And Jordan, you're right. This would be up your alley more than mine.
Yeah. And then Janine's question. So when she opens up her eyes, it's extremely overwhelming for her eyes, ears, head to take in and put everything around me in the right place. Her head, eyes, and ears can't process all of the stimulation in front and around wherever the eyes are looking. It's more relieving to look up or down, for example, at a gym exercising. It's way too much stimulation all around. I guess how best would we be able to help with a situation like that?
That we would be able to help with very likely, because she's describing a problem with the environment. And that's mostly what the glasses are addressing, how the environment, how overstimulating things are. There's filters of different types. There's lenses, there's ways to block off signals. So that would be something right up our alley.
Mm-hmm. Mm-hmm. Okay, perfect. And this is a good question. So Dee Dee is unable to travel due to her daily dysautonomia. One of her symptoms is convergence insufficiency, which along with that comes dizziness and balance issues. Do you have any suggestions in ways for her to get to a point of stabilization so that she could travel to
Yeah, I mean, we had one patient be drugged to get here, but yeah, actually for that, it can go quickly into convergence insufficiency because when I'm trying to find the picture. Let's see. Wait a minute. 14. Where's the picture? This one. Convergence happens at a conscious level. So it's the last thing that happens. So there's a whole chain of events with convergence coming after you decide, do I care to expend all the energy to look at a target and to see details? So when I hear people say, my big problem is convergence insufficiency, that is something that insurance companies use or eye doctors use to put as a diagnosis so that the insurance companies will cover the visit. But we don't look at convergence insufficiency as anything more than, oh, the patient doesn't have enough energy to converge. And if they do have energy to converge, it hurts them, or they are converging wrong because they judge space wrong, or they're converging wrong because the muscles don't move easily, or there's a discrepancy between signaling in the right and left. There are so many causes of convergence insufficiency that doesn't count. That's like saying, can you fix me? I'm not healthy. Well, not healthy because your nose is dripping, not healthy because you're having an allergic reaction, not healthy because you have cancer stage 4. There's so many different ways to not be healthy. Some can be helped and some can't. So Dee Dee's answer of convergence insufficiency, which is preventing me from riding in a car and driving, that doesn't make sense to me. Because if you cover up one eye, then your convergence insufficiency goes away because convergence is both eyes. So my first thought would be, did she ever try just buying a $5 eye patch and covering one eye and see if the symptoms go away? And if so, then she could travel.
Mm-hmm.
That would be something we could go offline. Jordan, maybe you could contact Dee Dee and get a little bit more history.
Mm-hmm. Yeah. Yeah, Dee Dee, if you want to reach out to us, fill out a new patient inquiry, or reach out if you've already spoken with a new patient advocate, and just let us know, and we're happy to go over anything with you on that too. We'll jump ahead here to Jody as well. The glasses that we talk about, she's wondering, how are they different from a prism glass? Just like something that someone else is out. She's 6 years out from her TBI and has off-balance feelings on occasion and ringing in the ears, along with myoclonic jerking.
Well, ringing in the ears is often from jaw tensing. When the jaw is tense, you get ringing in the ears, and the jaw can be tense from a lot of different reasons. The question is, what's the difference between our glasses and prism glasses? I often say prisms are like shoes. So there are shoes that are gym shoes, shoes that are beach clogs, shoes that are army boots, ballet slippers, spiked heels. So there's a lot of different shoes, and prisms come in flavors like that. There are prisms that are equivalent to the spiked heels. There are prisms that are equivalent to army boots. Some prisms affect your hips and your center of balance. Other prisms affect your shoulders and your eye position. It depends how the doctor has prescribed the prisms, because you can use prisms in different ways. Some doctors measure that your eyes are misaligned and they use prisms to realign them. That's working with the outside eyesight bucket. Other doctors use prisms to shift your posture and midline shifts. So it's more about your body and postural stability. So there's so many different kinds of prisms that there's no answer to your question. Our glasses sometimes have prisms and sometimes don't. Sometimes they're lenses, but our lenses are not lenses to make you see clearly straight ahead. They're lenses to enhance peripheral processing, which is on the outside. So it's really hard to answer that question. We use filters and lenses and prisms, as well as thinking games for visual processing. Because if you picture things in your mind and do visualization type activities, it forces convergence and divergence. So we're not really using prisms to align your eyes. If we use a prism, it's to it's to send the information in different spots on your retina. Your retina is an actual piece of your brain, and it's like a patchwork quilt, so that if you send signals to the bottom of the retina or the top of the retina or the side, these signals are routing through a completely different brain pathway. So we're using prisms, filters, lenses, and activities to build visual skills. We're not using prisms to align your eyeballs. I don't know if that answered the question, but I can't answer because I don't know what kind of prisms you're talking about.
Yeah, no, I mean, I think that that's a good explanation for, the differences and, the types of things that we do in association with that. Got another one. This is actually kind of a good, when we're talking about the glasses. Janelle's asking, so her husband's currently a patient. Can you talk about the adjustment to wearing the glasses and the goal for an amount of time to wear every day? Is that different for different patients? What does that process look like?
The process of adapting to a brand new set of lenses that are brainware is different for every single patient. I guess the process is the same. The amount of time is different. So we have people the first day putting glasses on and seeing how long it takes until they feel discomfort. That's the edge of their tolerance range, because you have a comfort range and then you have a tolerance range. So where you start getting to the edge of your tolerance range, that's when you start getting symptoms and feeling funny. So then they take them off and they note how long that time was. And they cut it in half and go the next day at that half amount. So if the first day they wore the glasses 2 hours, the second day they'd wear them 1 hour. But some people, the first day they can only tolerate them 4 or 5 minutes. The second day they might only use them 2 minutes. So it's very different amongst people, but the concept is half of whatever your tolerance range is. Then once they find their tolerance range and they cut it in half, they try the next day, but it still might be a little bit toward the edge of the tolerance range. So they'll cut that in half. And as soon as they find a spot where it's comfortable, then that's their number. So that could be 5 minutes and that could be 5 hours. It depends on the person. So if they have a tolerance of 3 hours and they tried 90 minutes, which is half, and it's still too much, they still have symptoms. They try 45 minutes, they say, that's okay. Then they would use 45 as their number and they would stay at that number, but increase the amount of sessions during a day to wear the glasses and then build up. And at some point, something will click in where their brain readapts and then they can wear them full time. In other patients, we use it alternating with a second pair of glasses so that we have something that's a little more comfortable and a little less comfortable, and they flip. So the concept of shoes still pertains. It would be like giving you a 1-inch heel versus a 2-inch heel versus a flat shoe. And you're having more flexibility, being able to wear any type of shoe in between.
Good. Yeah, we've got. Thank you for that. We've got quite a few questions from different people that are asking about, more specifically their injuries and their, neurological changes that occurred. Things like car accidents, medications that have had, bad implications, surgery complications that left a patient in a coma. Those types of injuries, the differences in these injuries, does that affect or change what we are able to do or how we're treating patients, or can you go a little bit further into that?
If you have somebody who's had a massive stroke and they've lost their eyesight and they can't move a leg, then we're not going to be able to get the same results as somebody who bumped their head and just needs to regroup. When they bump their head, something got unplugged in their brain and we just plug it back in a different socket. So the range of people we treat varies from people who just came out of a coma to people who, just want to play tennis better, or want to take 2 strokes off their golf game by processing more efficiently. So this again, there's not quite an answer to that question. We don't base things on brain damage. We base things on brain processing, what's left over. So even patients with macular degeneration, if your macula is degenerated and it's gone, you still have the whole rest of your retina left over, and we still work with what's left over. You can go to the eye doctor who's looking at the damage and saying, your macula is damaged, we can't fix it, take this pill to try to ward off more damage. We're not looking at the damaged areas, we're looking at what's left over that's still functional and saying, whatever's left over, let's teach you how to use. We can route lenses, we can use lenses to route signaling to hit good spots in your brain and ignore and circumvent the bad spots.
Got it. And are we managing issues like POTS and post-concussive syndrome at the same time when a person has multiple things going on? Are we able to address multiple issues or?
Yeah. Well, yeah, I mean, POTS, I wrote a paper on POTS back in 2011 when nobody had heard of POTS. And we had 4 patients that, I think it was 4 that we helped. But as an optometrist, we're not really dealing with POTS, but we see it a lot in patients, especially those with Ehlers-Danlos syndrome and mast cell problems. So when we have patients with POTS, we are not addressing the POTS, we're addressing the brain function. We're making the brain have less stress because we're equalizing auditory and visual processing. We're getting them to visualize their environment better. We're making the streams of information more balanced. So the POTS flare-ups often become lessened, but we're not directly addressing POTS.
Okay. So just fixing some of those underlying aspects.
Mm-hmm.
Okay.
Yeah. When you make the unconscious really stable by making retinal processing good, then that affects the subconscious, which affects the preconscious, which affects the conscious.
Mm-hmm. What if you're extremely impatient? You're I want to be better now, and you want change as soon as possible. Can you overdo it by wearing the glasses too long, doing too many things? How do you
Yes.
know that it's too much?
Yeah, well, because your body tells you. But if you're one of those people who doesn't listen to your body and just pushes through, that's probably you're your own worst enemy. So brains don't heal themselves. We don't heal brains. We build new pathways. But 2 aspirin make your headache get better. 10 aspirin are not 5 times as good for you. 1 Advil, every 6 hours is recommended. And if you take 5 Advil every 2 hours because you want to speed it up, it's just bad. So when people overwear their glasses, they have setbacks, and then that links into emotional. It's like a loop. You have a vicious cycle. So that's a bad thing to do.
Got it. Yeah. So definitely better to take your time and go through the process the right way, as opposed to trying to double up.
Mm-hmm.
Got it. Okay.
I mean, we had a patient that went into Walmart. She was doing great, then had gone to Walmart and Target the same day, and then just had a complete setback for, a week in bed. And it's like, why did you go to Walmart and Target? And she said, well, because I wanted to try out I was feeling so good, I wanted to see if I could handle it. Well, and when she couldn't handle Walmart, why did you then go to Target? Well, because Target has different lighting and I wanted to compare the two. Those types of things. You're looking for problems.
Mm-hmm. Yeah. We had a patient come in one time, and they, went and before their appointment did a bunch of, they went and saw the bean and went to some museums and a bunch of different things. And obviously, on a sensory standpoint, that's a lot for a lot of our patients, especially before an evaluation. So be careful. So these ones, a little bit of a shift here. This is kind of speaking a little bit more about syntonic filters, which is something that you've mentioned in the past. Brandon's specific questions are, what are the epsilon and omega syntonics doing? If you could maybe just go into kind of what are syntonic filters? How do we use them? What are they used for?
Well, true syntonic filters are they're different wavelengths, different colors, and often practitioners use them to do syntonic optometry, which is putting you in front of a light with the particular color for about 10 minutes and then changing colors for another 10 minutes. We don't do that here. We're using the same type of colors, but we're doing an indirect procedure. We're not using lights to go with it. We're not doing it 10 minutes at a time. And we're not always doing two different colors, but what it does is it works on the autonomic nervous system, whereas prisms would work more on skeletal muscles, and the colors would work more on visceral muscles, smooth muscles. The ones you just mentioned, the upsilon and the omega, upsilon is a calming effect for sensory signaling, and omega is a calming effect on motor skills, on muscles. So the omega acts sort of like a muscle relaxant, and the epsilon is cutting out sensory input. So when you're overwhelmed, a lot of times the epsilon there's another color that does that too, are helpful.
When we're doing testing on things like should we use syntonics? Are there measurable is there measurable data for kind of what we're looking at as far as looking at functionality and things? What are our measurable data points that we're looking at when we look at a patient?
The retina itself has receptors that respond to red and blue and green signaling, which are different wavelengths. So I'm actually giving a 2-hour lecture on this in Canada later in the summer. But what we're looking for that's measurable is the optic nerve activity. So when you put, say, a red lens on, the red wavelength, the red wavelength that comes in is only going to activate particular cells that are sensors. And then those sensors send signals to particular parts of the brain. So what we're measuring is which of the wavelengths give you good information, which allows you to process the space around you, and which of those wavelengths your brain says, I hate this, everything's confusing, I can't tolerate. So the markers we use would be electrical brain activity. We would use retinoscopy, which shows blood flow in the back of the eye, and we would use spatial perception. Those are the most common markers that we're using.
Okay. And when we're working with patients, is the goal for patients to, eventually there's rehabilitation where they're not needing to wear, the rehabilitation portion of the glasses. They're, not doing exercises later on in life. What's the eventual goal on this?
Yeah. The eventual goal is for them to learn how to control their environment, because most of our patients come in and the environment is controlling them. If the lighting changes, if something moves in their environment, their brain goes, whoa, I can't deal with this. Whereas other people, they just readapt. So the goal in the long run is for them to learn how to readapt when the sensory signaling is changed. That's why I said earlier, it would be like having shoes. You get used to wearing a 2-inch heel, a 3-inch heel, a 1/2-inch heel, a flat shoe. And then no matter what we throw at you, you just readjust. If you're always wearing flats and somebody hands you a 2-inch heel, your brain doesn't know how to handle it. So the eventual goal is that you should know how to handle any environmental change, whether it's through sounds or sights. And you would do that by being able to shift your body and not have pain and just readjust. So once you do that and you're able to be flexible, then you don't need the rehabilitative part of the glasses.
Got it. Okay. And are they, we've had quite a few questions about this. Do the glasses look weird? Are they funny looking, or do they look like normal glasses?
95% of the time, they look like normal glasses. Every once in a while, we might put a sticker on that looks kind of like Scotch tape. So then you get the Harry Potter look of people saying, what is that little piece of tape on your glasses? But most of the time, they look like plain, regular glasses.
Gotcha. And I mean, typically once a patient comes in, to the clinic for prescribing, glasses, how long does it take normally for them to receive those glasses?
It's usually about 2 weeks to get the glasses, and then sometimes it can be, a week or 2 or 3 to get used to the glasses. Sometimes longer, depending on the person. We have one person that was 3 seconds. She could only tolerate the glasses for 6 seconds, so she cut everything down to 3 and worked her way up seconds at a time. But she called back a few months ago saying, all of a sudden, it was a whole year, but all of a sudden something clicked and I'm better than I ever was. And it was similar to Clark Elliott's experience in The Ghost in My Brain, where it was one instant where he came back. And that's what she had said. It was years worth of a problem and then poof. So as far as how long it takes, a couple weeks to get the glasses, another couple weeks to get used to them, sometimes a few more. And then once you're used to them and you're on a journey of relearning things, then it can take several months. So depending on where you start, total rehab could be somewhere from 4 months, but it could go up to 2 years, depending on what you're starting with.
Okay. Okay. Do
And
a
how much compliance there is.
yeah, yeah. Do a little shift here on this. We'll focus on this. Inga had a question. If a child who is on the spectrum has limited verbal response, are you able to assess the child?
Absolutely. I mean, we do lots and lots and lots of infants, toddlers. Dr. Weil has had a tremendous background in infants. We assess them not by asking them questions, but by changing the environment and watching their response. So again, we're changing either sounds or sights or how they're sitting, their body position, or we're changing what goes in their retinas, and then we're watching the decision they make. And when I know what I put in and I know what comes out, we can figure out what's going on in their brain. When in order to give them glasses, you don't need them to say which is better, one or two. You can look with the light, and the light measures whether they're engaged in the environment or not. And we would put different lenses on to see which lenses would engage them in the environment and work from there.
Okay. And have we been successful in, helping to improve some, reading problems and, peripheral awareness and processing aspects in patients who are on the spectrum?
Absolutely. Yeah, that's my favorite thing to do. So yes, we've been very successful. But again, it depends on compliance. If you give somebody 3 things to do for homework and they come back and say, well, we did one, but my child didn't like the other 2, so we didn't do them, then you don't get the same results.
Yeah. Yeah. Okay. Okay. Let's see, we've got quite a few coming in here. Have you worked with any patients with PNES, psychogenic non-epileptic seizures, or functional neurological disorders?
I have not worked with that directly. For something like that, when we've had patients call in, we would send them to Alice Nixon, who's excellent at working with processing in the brain from a visualization standpoint. So I've worked with lots of epileptic seizure patients, lots and lots and lots of them. But the psychogenic ones would need first somebody working with the emotional systems, because you have sensory inputs and motor outputs, but in between is limbic processing. And the psychogenic, the non-epileptic seizures, that would be in the limbic processing area. And that's what Alice Nixon works with best.
Gotcha. Okay.
When she's finished with them, then they may not need anything from mind-eye.
Perfect. Okay. Let's see. Can you go a little bit? We've had a few questions on kind of the eye-ear connection aspect. Can you go a little further into, how does that all play into a, part, and does it affect, how does it affect proprioception? Those, those different things.
Well, they're all, when you're growing up, like as a baby, inside the womb from about I think it's the 4th month till the 9th month, your the mother moves around and your head position flops around. So you have your inner ear and your proprioception and the eye muscles linking together. When you're born, so you've had about 6 months in utero before you're born, where your head position and your eye position get all established. Then you're born, then you get another 6 months till you sit up, and that 6 months is used for that where am I pathway. You got your eyes and the head position linked together, but then you need to get the head position and the body position so you can sit. And then you get another 6 months where when you're walking at 12 months, and during from 6 months of sitting to 12 months of walking, where the proprioceptors and the vestibular system and the peripheral eyesight have to all kick in. And then you have another 6 months before you start running around, where you're judging movement with your peripheral eyesight easily. The first 6 months after birth, you're developing the peripheral eyesight. The central comes in later. So your question of how do the eyes and the ears and the proprioception all link together, during that time, you have auditory development also. So you're developing receptive language skills and eventually expressive language skills. So if the eyes and the motor skills and the ears have to link together at very specific times during development, and if you have a hindrance in one, so if you have a lot of fluid in your ears and ear infections, that will hinder the auditory development. If you have not enough peripheral stimulation in the eyes, that'll hinder visual development. Or if you have like a shoulder that's a problem, you have babies that come out and they hurt their shoulders or they fall, that can hinder visual development because when you're favoring a shoulder, your eye doesn't move as much. You can have a baby who has a multiple birth, like twins or triplets, where there's not as much room in the mother, so they don't get to move around as much. Or you get a bedridden parent, not parent, but a bedridden mother, and then the baby doesn't get as much movement. So any of those can delay the motor development. So again, the linkage of eyes and ears doesn't finish until about age 8. Monica Gori in Italy discovered that. And during the growing up years, the 2, 3, 4, 5, that's when sounds and sights have to be linked together by experiences. So eye-hand coordination, like learning how to catch a ball, that's developed. And people understand if you're 2 years old, you can't catch. If you're 10 years old and you still can't catch, there's a problem. But eye-ear connections are the same way. They have to develop. So if you're 1, you don't expect an eye-ear connection to be really good. But if you're 2 or 3 or 4, it starts to get better and better, so that when you go to school, eventually you can learn how to read using phonics and phonemic awareness and decoding ability, or you can switch to the visual method of sight words. So you have to have the visual memories developed and the auditory memories developed, and they got to link together through language. So that's a very long answer to a very short question. But basically, eyes and ears and spatial awareness develop based on experience, and the linkage is really important. And 22% of patients don't link those two, and almost, I think it was 90-something% of people who are on the autistic spectrum don't. So if you don't link auditory and visual information around you, you perceive the world differently. And that's what people on the autistic spectrum do. They perceive the world differently. They're not able to use those 8 channels of eyes and ears simultaneously. So they inevitably miss something. They're missing social cues or missing words or details or nuances. So.
Yeah. Okay. Got another question here. This one's a good one. So Miriam has a 17-year-old son, suffered a TBI in the fall of 2022. 3 months after he was given prism glasses by a neuro-optometrist, he developed visual disturbances similar to a psychedelic trip, circles within circles, fractals, static patterns, melting walls. They have consulted with a neuro-ophthalmologist who said, brain problem, not an eye problem. Done an EEG, MRI, nothing that can be fixed that they see. They've tried medication changes, down on Vimpat, up on Lamictal, but the symptoms are
Lamictal and what?
Vimpat.
Mhm.
Symptoms are still persisting.
So what you're saying there is that when we talked about the three buckets, that their outside world was affected because the non-image forming signals were activated. Um, so those are the types of things I would love to get my hands on, because we're working with when you had EEGs that show normal, the neuro-ophthalmologist is a specialist. It's a medical doctor who specializes in eye diseases that will affect the body. They're looking at problems in the eyes that are indicative of a problem in your body. So you're not describing that. You're describing a problem in the mind. So when you look here on this chart, the green circle here is chemical systems. Something triggered the chemical systems to go haywire to create the walls melting and all the peripheral hallucinations. You got to untrigger it by triggering something else. There are ways you can upregulate neurotransmitters through putting different glasses on. So, you know, that, yeah, that is something I would rather, if the person lives far away, then I would want to see a good history first, and you could try something with some local person there monitoring it. If the person lives in the Chicago area, I would have them come here.
Yeah. Okay. Yeah, I thought that you would find that one interesting.
Mm-hmm.
Elizabeth has a question. What's the extent that we can help with Parkinson's? Is it improving comfort, memory, attention? She's confident that the mind-eye can't change the actual Parkinson's disease itself, but what can we do to help with the symptoms?
That's a really good question. Um, each of my grandfathers had Parkinson's, and my uncle had ALS. So, and my other uncle on the other side also had Parkinson's. So, it's something I'm very aware of. Um, you basically Parkinson's affects sleep first, like 10 years before you get Parkinson's. There's often sleep problems. It also affects proprioception a lot. So with Parkinson's patients, what we can do is make them more comfortable by making them judge the space around them more easily. That would help balance, because that's a big issue in Parkinson's, of not being able to judge where something is. There's different kinds of Parkinson's. Some Parkinson's have dementia and some don't, but they've done new research now showing that the people who have dementia and Parkinson's have a thinning of their retina, and it's in the same space, like it's the same spot. So when we think of the retina as a patchwork quilt, it's always the same section. Uh, so you can monitor the thickness of that section, and I believe that you can stimulate that section specifically to hopefully slow down the deterioration of it. But as far as what we would do with the actual symptoms, you would basically make the space judgments better. They would have to learn a new skill and then practice that new skill so that their balance and gait would be better.
Okay. So definitely improving quality of life aspects.
Mhm.
Um, Heidi has a question. Could you speak about any, strategies for overcoming trauma flashbacks from, wearing the brainwear glasses? She has a trauma therapist, but would love some input on this issue.
I have a chapter in the book called Total War on PTSD. So to answer that, just because we're running short on time, it would be easier for us to send her a copy of that chapter, because that would answer her.
Okay.
So the book, it's Courtney Nold wrote it. You can get it on, it's the ebook is free on Amazon or on Barnes and Noble. Go to Barnes and Noble and it's Total War on PTSD, and you can download it for free.
Okay. And Heidi, feel free to reach out to us at the office too, and we can get that set up for you here as well. Another question here: Have you treated MS patients with eye issues or double vision?
Yes, lots, for 38 years.
Uh,
I mean, when you say treated, I mean, you can't make the MS go away, but you can make them lots more comfortable. And with them, you might have two pairs of glasses, so that if they have a flare up, they put one pair on, but if they feel much better, they put a different pair on, because one would be making them more comfortable and one would be pushing them a little bit so they learn and develop.
okay. We're at a little over 7 o'clock here now. if
What
anybody,
Jordan, what we did before, which I'd be happy to do again, is if we have a whole bunch of questions remaining, what we had done before is make like a little amendment and did a video of all those questions. And then when we sent the replay of the video out, we put that amendment into it. So everybody got their question answered.
yeah, that's perfect. Yeah, I've been going through and checking off those questions as we go. So what we'll do is, if your question, you've submitted that and, you know, we haven't gotten to that, we'll do that. We'll make an amendment video. We can try to answer as many of these as possible. If, you know, for any reason you're not seeing that on the video replay, you know, please reach out to us. You can go to the mindeye.com/contact. And reach out to one of us. We can, you know, we can definitely answer any of your questions or get you in touch with one of the doctors to, you know, discuss things further. You know, we're, like I said, always happy to help.